Okay, let's talk about pyelonephritis now. We did talk about already the acute cystitis, which is the bladder, inflammation of the urinary bladder. Now let's talk about the kidneys. Pyelonephritis. You have acute and chronic. In acute, you have the neutrophils infiltrate and renal institution. Okay. If you got the morphological eyes, you can take a look at that, but I don't know. You know that acute inflammation is always neutrophils, so okay, we got the neutrophils, great. Affects the cortex with the relative sparing of the glomeruli, the vessels, so it only maximally affects the cortex and relatively spares the glomeruli or the vessels. Now, it's going to present with those systemic signs. Okay, which are fever, flank pain, very important. Flank pain, very important. Okay, now all the questions they're gonna say costo-vertebral ankle tenderness positive. So CVA tenderness positive. That's the right way you can think about it. Something with the kidney, which is most likely pyelonephritis or any inflammation or anything like that. Then you have the nausea, vomiting, and chills. But remember, since in here they haven't talked about the signs that they have talked about over there, dysuria, urinary frequency, and all that. So you will see all of them in this thing too. Dysuria, urinary frequency, urgency. Suprapubic pain is more specifically for the urinary bladder. Suprapubic pain, okay. But here dysuria, which is dysuria meaning painful urination, and all the urinary problem, you will see that. Plus you will see systemic signs, which are fever, flank pain, nausea, vomiting, chills. Okay, now let's talk about the causes of this thing. Why do we have acute pyelonephritis? We have the ascending UTI. Ascending meaning it went from urethra to bladder, from bladder to ureter to kidneys. That's the ascending UTI. E. coli again is the most common cause. Hematogen is spread to the kidney. Presents with WBCs in the urine. Causes include ascending UTI, or second thing is the hematogen is spread to the kidney. So one thing we're going to talk about is the ascending. The other thing is from the blood it goes to the kidney. Presents with WBCs in the urine plus minus WBC cast. WBCs, those neutrophils are going to come in urine, and when they slough off or when they die, they form a cast in those small tubules, and those casts can also be seen. Maybe, may not be, plus minus. CT would show striated parenchymal enhancement. Risk factors include indwelling catheters, urinary tract obstruction, which I talked about already, vesicoureteral reflux, diabetes, pregnancy. What is the pregnancy going to do? Progesterone-mediated decrease in uterine tone, and compression by the gravid uterus. Okay. And then you have the complications include chronic. It can lead to chronic pyelonephritis, renal papillary necrosis, or perinephric abscess with possible posterior spread to adjacent psoas muscle. Very important. So acute pyelonephritis can form an abscess if it spreads, if the infection spreads in the psoas muscle. It's called perinephric abscess. Okay, because the psoas muscle is just behind it, and you will see a lot of things on psoas abscess, iliopsoas abscess. Okay, so just remember that UTI or the acute pyelonephritis, inflammation of the kidney, is one of the causes that can lead to psoas abscess. Then you have the urosepsis. Treatment, again, antibiotics. Okay, let's now talk about the chronic pyelonephritis. In chronic pyelonephritis, you have the result of recurrent or inadequately treated episodes of acute pyelonephritis. So either you have recurrent pyelonephritis that can lead to this, or you didn't treat it well. That's why you have this as a complication. Typically, it requires predisposition to infection such as vesico-ureteral reflux or chronically obstructed kidney stones. Okay, so typically it requires, if it is not this thing, like you have already treated acute pyelonephritis, but the patient is getting chronically infection again and again, recurrent infections, so you're going to think about vesico-ureteral reflux or some chronic obstruction of the from obstructing the kidney stones. So some chronic stone that is obstructing the kidneys, or the vesico-ureteral reflux. Coarse asymmetric corticomedullary scarring, blunted calyces will be seen with chronic pyelonephritis. Tubules can contain eosinophilic cas resembling thyroid tissue. It does resemble somewhat thyroid tissue, which is thyroidization of the kidney. So this kidney resembles thyroid tissue. If you can see those follicles and those thyroidization of the kidneys, thyroid tissue. So that's the thing we have here. Then you have this xanthogranulomatous pyelonephritis, which is a rare, grossly orange nodules that can mimic tumor nodules, characterized by widespread kidney damage due to granulomatous tissue containing foamy macrophages associated with the Proteus infection. So if you were to develop some orange nodules that you can think of as tumor, but they're not tumor, this is basically a widespread granulomatous inflammation with the foamy macrophages, most commonly associated with Proteus infection, Proteus mirabilis infection. Okay, so that's what we have. So just to rephrase a couple of these things. Acutely, you have an acute infection, you can treat it, and most importantly, the presentations are the things here that's going to present with all of that, right? And the risk factors are of that. You have either the catheter or the obstruction or the VU or the diabetes or the pregnancies and all that. But that can develop into chronic if you do not treat it, or if you have the recurrent, you can think about again VUR or the obstruction. Now, because you have the chronic, you have the thyroidization of the kidney, which is a coarse asymmetric corticomedullary scarring and blunted calyces. Okay, and one other phenomenon, if you want to think about it as a tumor, like orange nodules, if you see something orange, is xanthogranulomatous pyelonephritis. Because of the foamy macrophages, there's a widespread deposition of granuloma formation with the foamy macrophages, seen as orange, seen with the Proteus infections. Okay, that's pretty much all we have for the pyelonephritis.